Thank you so much, Gabby, for the introduction. So I'm Lavinia. I have been affiliated with the University of Miami for the past 10 years. I've been working in the field of hepatology, and I'm happy to present a clinical case today and to discuss lifestyle management of fatty liver disease. So lifestyle management is the topic for today. So we start with the clinical case. We have our 65-year-old Hispanic man with a history of hypertension, hyperlipidemia, diabetes, and an elevated BMI of 29. Let's call him Albert, who was referred for evaluation for elevated liver enzymes, for which his PCP ordered an ultrasound, and he was noted to have increased liver echogenicity suggestive of steatosis. Important to mention, there is no history of heavy alcohol use and actually no alcohol use for a few decades. On exam, we can appreciate the central abdominal adiposity with otherwise normal findings, thus no stigmata of cirrhosis or portal hypertension. And the labs confirm his diagnosis of diabetes with a hemoglobin A1C of 7.2. Cholesterol seems well controlled. And ALT elevation is said to be mild. Levels have been fluctuating up to 2 times the upper limit of normal for the past 3 years. All right, so here on the left, we actually have the workup. Oh, sorry, I went too fast. Here on the left, we have the workup that's been done and the conclusion that the management should consist of lifestyle modification and metabolic disease management. However, in order to understand how we reach this decision, we will review the MASLD AGA clinical pathway flowchart here on the right, which will help guide us and our colleagues in other specialties, primary care, gastroenterology, endocrinology, when screening patients for fatty liver and fibrosis, which of course is something we strongly encourage, especially in at-risk patients, such as those with features of metabolic syndrome, ranging from hypertension, hyperlipidemia, obesity, with a special focus on diabetes, as it is a known predictor of greater disease severity and poor outcomes. We know that the vice versa is also true, and MASLD can in turn increase the risk of developing metabolic syndrome. So it is important to exclude other causes of liver disease, autoimmune hepatitis, and other metabolic disorders through doing the serological workup, as well as excluding competing etiologies for steatosis. And I'd like to point out the importance of assessing pattern and quantity of alcohol use and identify patients that fall under a different category of alcohol-associated liver disease rather than MASH, as well as those who belonged to the new entity of MetALD, which is meant to encompass patients with metabolic syndrome who happen to consume alcohol quantities exceeding the allowed amounts of 140 grams per week for women and 210 grams per week for men. We also have to keep in mind the possibility of underreporting of alcohol use, which is not uncommon, and consider PEth testing whenever there is clinical suspicion. So this classification distinction into the several subtypes of steatotic liver disease will become that much more important when we assess candidacy for pharmacotherapy, as these patients will have to be excluded. So the evaluation starts with the basic blood tests, CPC, CMP, followed by NITs, non-invasive tests, which in the current climate have replaced the liver biopsy for staging of liver fibrosis. Though I would also mention that whenever a biopsy is required or performed for excluding other etiologies of liver disease, or even just to confirm fibrosis, its findings would supersede any other tests if there is a discrepancy between results and a treatment decision must be made. So we now have at our disposal several NITs, such as FIB4, ELF, Enhanced Liver Fibrosis, FibroScan, and MRE. And sometimes they can be inconclusive, and more than one will be required to confidently establish the fibrosis stage. And on that note, it is important to also mention that FIB4 in isolation should not be used to exclude the patient from treatment. The results can vary depending on the values that are included. Sometimes it's the platelet count that can be low for different reasons. And also we can see an overestimation of the score due to advanced age in older patients. On the other hand, we can use also the labs to recognize signs of advanced liver disease in otherwise asymptomatic patients, such as thrombocytopenia, hypoalbuminemia, which would be telltale signs of advanced liver fibrosis. So we have here the FIB4 interpretation with a low, indeterminate, or moderate and high risk scores for, to predict advanced fibrosis. So on the lower end of the spectrum, the patient should be managed with basically a focus on management of the metabolic syndrome. In the high-risk population, they should be referred to a specialist, of course. I would like to stress a little bit that the intermediate or indeterminate risk patients are basically at a turning point when the early recognition of liver disease and early referral will in many cases make a difference in prognosis and sometimes overall survival. So here's what we need to pay attention. For our patient, the results are listed here on the left. So his ALT was 43, slightly out of range, AST 38, platelet count is preserved. The calculated FIB4 is 2.22, so he falls under the indeterminate risk for advanced fibrosis category. So he needs further investigation with a second staging strategy, in this case achieved with a FibroScan, which showed a median liver stiffness of 6.7 kilopascals. This corresponds to minimal fibrosis, stage F0 to F1 perhaps. And so the plan for Albert would be to focus on optimizing his metabolic syndrome, repeat NITs in 2 years, because we know that fibrosis occurs over time, progression occurs over time, so more frequent testing is generally not necessary unless there are other changes in the medical history. So going forward, this is an overlook basically on the risk factors and the diagnostic criteria for MASLD, including 2 or more features of metabolic syndrome or obesity or diabetes, plus evidence of steatosis, steatohepatitis, and or fibrosis on NITs. Highlighting here one of the most favorable aspects of liver disease, which is that the liver does indeed regenerate and fibrosis can be reversible in early stages, specifically if cirrhosis has not ensued. Also important to note that steatosis alone is a risk for developing liver cancer, more so in patients with advanced fibrosis, of course. Nonetheless, appropriate screening is recommended in this patient population. So a note on genetics and its role in the pathogenesis of fatty liver. We all have patients carrying a diagnosis of MASLD, which seems to have come out of nowhere and catching everyone by surprise. So included here are a few details on the genetics role, such as mutations in the PNPLA3 gene, which encodes for protein I148M. This leads to lipid droplet remodeling, and it causes a decrease in the breakdown of triglycerides into glycerol and fatty acids, and also a decrease in the transport protein. Other genetic mutations in the MBO87, TM6, SF2 genes essentially contribute to increase de novo lipogenesis, decreased fatty acids oxidation, decreased transport, and eventually leading to steatosis. To all of this, of course, we have to consider the added contribution of external factors, the elephant in the room, which is diet. As we know, poor dietary choices lead to increased inflammation and oxidative stress. And we have here high fructose corn syrup products, the sodas, the saturated fats, which will lead to increased steatosis and increased inflammation. This slide essentially highlights a previous note that there is an interchangeable relationship between obesity and diabetes and MASLD, whereas both obesity and diabetes increase the risk of developing fatty liver. The converse is also true. Fatty liver patients are at risk of developing obesity and diabetes, and they also have other risks such as cardiovascular and others. So how do we manage MASH? Management of MASH, we briefly talked about the exclusion criteria for the FDA-approved MASH treatment, which is resmetirom. So we know that there is a large cohort of patients who will not qualify for pharmacotherapy based on the level of fibrosis, based on comorbidities such as alcohol use. But even for those who do, lifestyle modification is of utmost importance, and if they will hope to achieve a favorable response, meaning reduction in steatosis and/or fibrosis. So weight loss is still the #1 recommendation for MASLD, as most patients do have an elevated BMI. And even in the cases of lean MASH, lifestyle modifications, healthy diet, exercise with building of muscle mass have proven beneficial. So we have here a comparison between a patient with obese MASLD and a healthy weight MFLD, which again, a normal BMI will not exclude underlying MASH. Body habit is, of course, worth mentioning because I think we all see those patients who do not look overweight, do not feel or think they are overweight, but what they do have is an increased abdominal girth, aka central adiposity, which is actually the major promoter of insulin resistance and pro-inflammatory signaling. So paying attention to all of these details will help identify patients at risk, even when it is not very obvious. So our patient, Albert, admits to eating a typical Cuban diet consisting of rice and beans, red meat, pork, plantains. He's not very fond of vegetables or seafood. When it comes to diet, we know that we have to consider the limitations that are related to cultural preferences, ethnicity, but also socioeconomic status. And changing everyday habits can be very challenging. Therefore, what I find very helpful is to have a tailored plan for each individual patient. And sometimes that would imply counseling, for example, by a mental health expert whenever we suspect eating disorders or using diet as a way of coping with life stressors, underlying anxiety, etc. But generally speaking, implementing a multidisciplinary approach can be very helpful, which is why I encourage early referrals to dietitians, endocrinologists, and more often also to weight loss clinics and bariatric surgery in order to discuss eligibility for agents such as GLP-1 agonists, for example, which are beyond the scope of this presentation, but still worth mentioning. So weight loss was linked directly to improved histological outcomes. So we know that 3 to 5% of body weight loss correlates with improved steatosis, over 5% improved ballooning, 7% leads to MASH resolution, and over 10% body weight loss can result in reversal of fibrosis. Mediterranean diet has been the agreed upon diet as having the best evidence for improving steatosis. And of course, we have to consider the genetic polymorphism, which plays a role in how each individual will respond to the same lifestyle changes. This can be very frustrating for many who will at times feel like giving up, and they end up stuck in a repetitive cycle of weight loss and rebound weight gain, which eventually leads to perpetuation of disease. So especially in these cases, the multidisciplinary approach becomes all the more important. The second aspect or component of lifestyle change is, of course, increased physical activity, and the importance of it cannot be overstated. We have here illustrated and compared and contrasted also aerobic exercise and resistance training. And essentially, both equally help dissipate steatosis through different pathways. And it seems that resistance training does so more efficiently by investing less energy. All the while, one of the most intense and promoted and famous exercise activities like HIIT, high-intensity interval training, was actually not proven to be effective. So with aerobic exercise, we have the benefit of upregulation of proteins with crucial roles in metabolism, such as uncoupling protein 1, UCP1, and PPAR gamma, peroxisome proliferator activated receptor gamma, which have beneficial effects on adipocytokines like leptin. These are the signaling molecules that play a key role in regulating hunger and satiety, and thus influencing body weight. On the other hand, resistance training leads to muscle hypertrophy and increase in the signaling molecules released from the muscles called myokines. The important thing to remember is that no matter the pathway, these molecules not only will have local effects in the adipose and muscle tissues, but also have an impact in distant organs and systems, and overall improve glucose metabolism, reduce cardiovascular risks, enhance cognitive function, and even immune modulation. So big surprise, right? Calorie restriction is the mainstay to achieve weight loss. And I would be remiss if I didn't mention here intermittent fasting. The typical schedule would be the 16 with 8 hours, 16 fasting, 8 hours window to eat healthy foods, though this may not be feasible for some with underlying conditions such as diabetes or for older patients. We talked about the Mediterranean diet, which is supported by AASLD, AACA, the American Association for Clinical Endocrinology, European societies as well, and it is recommended as a primary lifestyle intervention. So for our patient Albert, who returns for a follow-up, he did make some efforts. He cut the soda and other carbohydrates and sugars, but has not been able to include an exercise routine into his schedule. And we hear this a lot, but being active at work, unfortunately, won't have a significant impact on prognosis. So our patient tried to make some changes with emphasis on tried. And this is very commonly seen in clinical practice because we know lifestyle change is one of the most difficult things to do. And so it is up to us, the medical providers, to continue to be supportive of their journey, however slow or fluctuating it might be. So the way to inspire change is by offering positive reinforcement, appropriately using all possible resources at our disposal, such as referrals to other specialties, and by thorough discussions with the patients, promoting compliance, consistency, and accountability. I also found that journaling can be very stimulating, and celebrating small progress can have a snowballing effect. And we can also implement this exercise and diet adherence scale, EDAS, for patients who are willing to participate. This is a voluntary questionnaire including 33 criteria, which can be performed at baseline and after 6 months as well. And it can help gauge the level of commitment of our patients. And in not so successful cases, for example, it may be helpful in identifying and addressing any limitations that may stand in the way of their pursuit of a healthier and happier life. So I just wanted to include this at the end. It's one of my favorite quotes. We've all got both light and dark inside of us. What matters is the part we choose to act on. That's who we really are. So it just kind of highlights the importance of obtaining the cooperation of the patients, acknowledging that we have a dual nature, and the progress will not be linear. We may experience ups and downs, but in the end, the progress is possible if we are all working together and channel our efforts in the same direction. So with that, I want to thank you for your attention, and I'd be happy to answer any questions if there are any.